in palliative care. For the next 3 sessions, we'll be dealing with topics which are very important but yet very less discussed: ethics and communication. And as a first part of that, today we'll be going through the different aspects of medical ethics. And we have an eminent and vibrant faculty joining us in the evening to walk us through the same. It is indeed my personal privilege and pleasure to welcome Dr. Sanghamitra Bora. Let me introduce her to this batch officially. She is the lead of palliative care in Assam Cancer Care Foundation. She has completed her MSc Palliative Medicine from Cardiff University in the year 2017. She is an active volunteer of Arjeevan Healthcare Foundation and an active IAPC National Faculty also since 2010. She's a certified national trainer for the NHSRC, National Health System Resource Center, under the Ministry of Health and Family Welfare, Government of India. And she is a very active member of various palliative care associations and a very close friend of Pallium India. So, ma'am, it is indeed my privilege welcoming you to this batch, ma'am, and it is over to you.
Thank you. Thank you so much, Ripriya. And it's so good to be back for these very wonderful sessions conducted by Pallium India. And I'm sure that everybody has been enjoying all the sessions till now. So as Shripriya said, we need to know something about ethics also, because I think the problems in a doctor's life or a professional lives, are always surrounded by ethical dilemmas, problems with, what to do, what not to do, etc., etc. So I'll just share my screen. Give me just one. Okay, so, okay. Yeah, is my screen available to, visible to everyone?
Yes, ma'am, not in the slideshow mode.
Yes. I'll just put it in the slideshow mode. Right. So, yeah. So we'll be talking about ethics in palliative care, and it's a huge subject in itself. So I will not be able to, cover the whole of it in one go. But having said this, whatever is important, the points that we need to understand, we need to know about ethics, and at the same time, touching upon some practical aspects that we may encounter in day-to-day palliative care practice. So we'll touch upon the definition and then the 4 cardinal principles, and of course the hot topic of euthanasia, because I decided to do some discussions on euthanasia, because that is one of the hot topics that you will be facing perhaps if you are really working in palliative care. So sorry. Yeah. So palliative care, the ethics of palliative care are that of medicine in general. We all know that as doctors, we have dual responsibility. Firstly, we are all taught and we want to preserve life. And at the same time, we need to relieve suffering of people. Okay. So these are the 2 important responsibilities, the prime responsibilities of being a doctor or being a nurse or being a healthcare worker. So, but having said this, at the end of life, the relief of suffering becomes more important as preservation of life becomes increasingly impossible. And that is very much relevant to palliative care practice, because I work in basically in cancer setup, and I get patients who are at the end of life, mostly in the end of life, for end of life palliative care. And I'm sure that those of you who are working in palliative setups already, or are working perhaps in ICU setups also, will be faced with preservation of life, in comparison to relief of suffering. And you must be facing a lot of difficulties with caregivers, with the family members, what to do, what not to do. You have to understand that the end of life, relief of suffering becomes very, very important. And as the preservation of life becomes impossible. So there are 4 cardinal principles as applied to palliative care practice, and definitely medicine in general. So these are, you all know about patient autonomy, beneficence, non-maleficence, and justice. So autonomy definitely deals with, what does the patient want? And in palliative care, we, take care of the family as well. And henceforth, the family, we need to understand what the families understand about their patients' preferences. What do they really know about what the patient wants? So that is about patient autonomy. Secondly, it is beneficent, which is will it benefit the patient? Whatever we do, or whatever action has been taken for the patient's treatment, or bringing the patient into a relief of suffering kind of an environment, is it going to benefit the patient out of that? Thirdly is non-maleficence, which is definitely, will it harm the patient? And then justice. So we are in a resource poor setting. India is a low middle income country, and many of us have had at one point in time definitely worked in resource poor settings. So how do we justify allocation of resources for our patients? So that is justice. So I'm just coming one by one, but before coming to that, why do we need ethics? Why, what is the reason that we're talking about ethics and following principles of ethics and things like that? So the point is that we, in our day-to-day practice, we are faced with certain situations where we really become puzzled and confused, that we don't know what to do next. We feel that one of our actions is going to save the life of the patient, but at the same time, we understand that that particular action might also harm him. Okay, so that is known as a dilemma. We know that the action that we are going to take, is beneficial for the patient, and at the same time, it may not, serve up to the expectation. So that situation is known as ethical dilemma. And so we need to understand how to negotiate our ways out of those dilemma, and which action should we take in order to give the maximum benefit to our patient, and trying to build an environment where every aspect of patient care is met with. So ethical dilemma is basically a conflict of moral principles occurring when a person faces certain situations where adhering to one particular principle might result in the violation of the other. Okay, so this is the reason why we need ethics in our lives, why we need to understand the dilemmas in following ethical principles, and how we are going to negotiate our ways through certain situations. So from here on, I would request all of you to, give your inputs in the chat box, or even if you want to talk also, you can talk. But I'm going to show you certain situations, examples, where I would like your opinion also, so that we can discuss these cases and then go forward. So, so there is a patient, and this patient has been counseled for NG tube insertion. Okay, so he has a jaw tumor with a orocutaneous fistula. And I'm sorry, there was actually a picture. I don't know why it is not coming in this presentation, but I want you to imagine that there is a patient with a jaw tumor with a orocutaneous fistula. He's an elderly person. He's in extreme pain, and there is no distant metastasis. But he refuses to take the NG tube. So what is your stand? What do you want to do next? The patient has come to you. He doesn't have metastasis. So that means that, he can be treated further. But in order to continue with the treatment, you need to insert a nasogastric tube. But the patient is refusing. So how do you go forward? What do you do? So I just need, one or two inputs from your side so that we can just go ahead with this. Yeah. Can we have some, anybody who would? Okay, so Dr. Harsha says, I would counsel the patient to put in the NG tube as it will help with his nutrition, correct? So why not a PEG tube? It can be less discomfortable. Okay, all right. And then IV fluids, maybe sit with the patient and counsel and make him understand, explain to him fully the benefits, counsel and provide information, ask the patient why he is refusing. Yes. Okay. So I really have really good inputs here. Thank you so much. So just a second. Yeah. So now I think every one of you who have actually put in your responses in the chat box are correct. Correct in the sense that, first of all, we need to decide on how to approach this patient. Okay. So firstly, let us consider what is happening here. What is happening here? Now, the point is, you want to, sorry. So this is a dilemma where you want to benefit, do good to the patients. Okay. So it is a dilemma between doing good, that is putting the NG tube, and trying to give the benefit of treatment or cure to this patient. And at the same time, you have to respect the choice of the patient, which is autonomy of the patient. So we are in a dilemma between what to do, because both are ethical principles. We just cannot, violate any of these. Okay, we cannot leave it just because the patient is not wanting it, because we know that putting an NG tube and thereafter proceeding for treatment is going to do good for this patient. So how do we approach this patient? Just a second. Let us understand what is patient autonomy at this particular point of time. Okay, so firstly, the patient is involved in decision making. The patient has the right to have the dignity, privacy, and confidentiality, the right to have information, the right to make the decisions. The treatment decisions must come as an informed choice of the patient. So this is the point where, we have to understand what are those things, what are the rights that the patient have, and what are those particular important facts which make up the patient autonomy. Okay, so we know that the patient must have the right to dignity, privacy, and confidentiality. The patient must have the right to have the information. The patient also needs to have the right to make the right decisions. And at the same time, the treatment decision must come as an informed choice of the patient. So here in this particular case, the patient must consent to, giving the decision of taking the NG tube from his own side. We cannot actually force this patient to do anything. So now for this particular patient, what is the autonomy? We need to take an informed refusal. Okay. First of all, if when we, try to take an informed refusal, we must check the understanding of this patient. Okay. And all these things will actually come when you know the skills of communicating with the patient, the skills of communicating with the patient party. Okay. So definitely that is going to be covered in your communication skills modules. But here, you need to take an informed refusal by firstly checking the understanding of the patient. Does the patient actually understands why we are going to, put an NG tube? What is the benefit of taking the NG tube? Okay. And then explore the reasons. If you come to know that the patient, is actually, maybe running out of money, or the patient fears that, the NG tube is going to hurt him somewhere else, it's going to get inside some other organ of the body. All these reasons need to be explored. And then you start counseling. Okay. Counseling is just not, giving all the kind of gyan or all kind of information or, all kind of scientific things that you know about to the patient. It's nothing like that. It is firstly to understand why he is refusing the NG tube or any other procedure. And then, these reasons need to be explored one by one. You need to understand, put yourself in the shoes of the patient, empathize with his situation. He might say, I don't have money. Who's going to make, all the churning and a liquid diet for me? I can't do that. Nobody is there to take care of me. So all these reasons would be explored. And then you start counseling. You start counseling by a proper process of addressing every issue that the patient shares with you. Okay. And then after counseling, the patient still refuses. The patient says, no, whatever has happened, I've shared with you all my problems. You have tried to help me, but doctor, it's not possible for me to take the NG tube. Okay. So you will need to support the patient, even if he or she doesn't agree with your decision. And that is what we are made of. Okay. We will have to, it's not that we are angry at the patient. We will be angry at the patient. Okay. That's a natural, because we are also human beings and we want to do good. Okay. Anger definitely comes into oneself very naturally. But then, having said this, our maturity would come only when we support our patient, even when the patient is not agreeing with our decision. But having said this, in my career, short career, I have actually come across patients who have refused certain procedures, and I have supported them. My team has supported them, and at after a certain period of time, maybe a week or maybe even after 2 or 3 days, the patient actually comes back to you And he says, doctor, I think you are right. He ponders over what conversation you have had. It's the kind of support that you have shown, even if the patient is not agreeing with you. I think that particular thing comes only after a certain period of rapport building with the patient. The patient understands that this doctor is actually wanting the good of me, is trying to help me, and that realization actually brings that patient back to you. Okay, so in this particular case, we need to take an informed refusal. We will stand with the patient, even if the patient doesn't agree with me, agree with the doctor. And at the same time, later on, we keep the door open for this patient to come back to us and tell us, that he wants to take a NG tube. Okay, so I'm really sorry. I don't know what is wrong with my PPT today, because there was a nice picture of this boy, and this is another case. He's a 20-year-old boy with the osteosarcoma of the lower end of the femur. He has a large tumor as of now. He also has multiple lung metastasis, and he is suffering from severe anemia because of this particular tumor. So he wants an amputation now. He tells you that I want to do an amputation. He's already been, referred to palliative care for you by the treating oncologist, the surgical oncologist, the team. But now he says that I really want to do an amputation. Okay, so you understand that the procedure is extremely risky, considering the whole of his condition, and you do explain the risks to him, but he wants to continue with the amputation. So what is your stand? What are you going to do with this particular patient? Can we have some chats?
Ma'am, you want me to share that picture in case?
Yes. Shri Priya, if you have, it will be really
Yes,
nice.
I
I
do.
don't know what is wrong today. I'm so sorry.
No worries, ma'am. I was just thinking earlier also, I thought maybe if you wanted support, I can share it.
Yeah, maybe Shri Priya, you can run your presentation. I'll just stop this.
Yeah.
Okay, will that be okay?
Yeah, fine, ma'am. I can do.
Yeah, okay, just one.
I hope it is visible now.
Yes. For me, it's visible.
It's visible now.
Visible? Yeah. Okay. So, okay. Anybody wants to share your thoughts on this particular patient? Okay, so Dr. Chris Steve has said he has multiple lung mets, absolutely, and no need for more pain and invasive intervention. Okay, that's a decision that we need to take. So ask him why he wants the amputation, and also explain to him what will be the outcome of the amputation. Yeah, true. Okay, I will explain him about the outcomes, definitely. Dr. Tino says, explain all the risk consequences, death on table, and go ahead with the procedure, right? Okay. Discuss with him the harm versus the benefits. Okay. Anything else? All right. So this is an ethical dilemma. Yeah. Can you please get the next slide? Yeah, so this is a dilemma between doing good. Okay, how do you want to do good? We know that the patient will die on table if he's operated. Okay, so we want to avoid the harm of getting the patient his choice of treatment. All right, and also doing good in the sense that the patient is also wanting that particular operation. Okay, so it's a dilemma between beneficence and non-maleficence also. All right. So now, how do we approach the patient? Next slide. Next. So somebody in the chat box actually, came up with this particular question of, is the survival likely? Will the amputation improve this condition? Okay. So what are the chances of cure? We need to understand this ourselves, and we need to put this across to the patient also. Okay. Somebody did mention about, what dying on the table, and I think, yes, somebody did mention about this. So we will need to give him the information out here. Okay, all sort of information that we, because the patient is asking that from us. Okay, tell him what are the chances of his survival after doing the operation. Suppose we take him to the OT table, we operate him under certain conditions with the kind of anemia and the general condition that he has. Is he going to survive this or not? Okay, and suppose by all sort of means and all sort of support, the operation does happen, will the amputation improve his condition? What about the lung metastasis? So here also, you will need to maintain the kind of honesty, which is very much important, to let the patient know very realistically about his prognosis, about the kind of future that he has. Okay, maybe he might also want you to tell him that his days are numbered. Okay, so this is regarding this particular dilemma. Can we go to the next slide? Okay, so another dilemma that we have here is, take this same patient, okay, this 20-year-old boy, and he has an advanced cancer. So you must be, some people, those doctors here who are working in palliative care setups, in basically in cancer care, you must be knowing that there are relatives of people who do not really want you to tell the diagnosis and prognosis to their patient. Okay, they'll come and tell you, please don't say anything to my patient. Otherwise, he'll die on the table, die after hearing, he'll have a heart attack, all these things. Okay, so the relatives, they have insisted that issues of diagnosis and prognosis should not be discussed with this 20-year-old boy. So when you go to see him one day, he's alone, the relatives are not there, and he very nicely asks you what is wrong with him. Okay, so what will you tell him? What do you think you should tell him? Anything, any sort of response from your side? Okay, you want to tell him the truth. Okay, I should ask him why he asked me. Okay, so again, explore the reasons. So Anjali has said patient has the right to know their condition. So try to counsel the relatives. Absolutely, yes. Explain the truths. We have to tell him the truths. Tell him the truth, but ask him what he knows. Okay. So first we can ask him how much he know of his condition till now. Very good. So this is something also related to communication, breaking bad news, or communicating bad news, or you'll come to understand about a situation where the relatives do not want their patients to know, because this is what happens. There's a lot of collusion, and you will understand how to manage collusion when you go through your communication skills. Okay, so here, this patient, how do we approach this patient? What to tell him, what not to? Again, explore the sides of what he wants to know. How do we make him understand what his problems are, what are his prognosis? Okay, but at the same time, we also need to understand that the relatives will not be privy to this. Okay, so if we do not have the parents or the relatives of this person by our side, we are actually creating a kind of a enmity with this particular relationship. Okay, so what will happen? The relatives will think that we have told this doctor not to tell our patient what he is going through, and this doctor is not understanding our point. So we are going to take our patient to somewhere else where he will be protected, okay, from coming to know about this bad situation. So basically what is happening is that the relatives of the patient are trying to protect him from getting this bad news. Okay, they're not wrong in their approach, in their thinking. It is because of the fact that they want to protect their child. A 20-year-old boy for a parent will always be a child. All right, and if these relatives, if this family is actually trying to trying not to tell this diagnosis and prognosis to their child, it means they're trying to protect him from getting hurt. All right, so we have to understand that point also. So the basic idea for us, the basic point here would be to actually at this point actually tell this boy that, okay, there are certain aspects of your disease or your condition that we would like to definitely discuss. But at the same time, I want your parents to be here with you so that we can, speak at length. I will make some time, to discuss this. And this will be my priority, maybe towards the end of this day. And I will take out a good, amount of time, maybe an hour or so, to come and sit with you and your parents together, and we can discuss this. Okay. So, when you start doing that, the parents are also convinced that, maybe this is the real time that you will want to tell this patient about his diagnosis and prognosis. And, there would be some kind of protection so that the patient is not hurt. At the same time, you must have a session with the parents also, where you will need to tell the parents that, look, when he is asking what is wrong with him, we have to take this into consideration, that he knows that something is wrong with him. He also knows that after such a long time of treatment, when he's not getting better, there is something which is bothering him, and we have to address that. And that is the right of this patient. Okay, so you have to make an amicable situation where the patient and the family members are in one platform, and you get to discuss this at length, give the diagnosis in a non-threatening way and the prognosis in a proper manner, so that both the parents and the patient understand what is going through and what lies in the future. Okay, next slide, please. So the question in this particular patient, was, is it right to deliberately mislead a person? For example, if you had gone by what the parents had to say, you would have actually landed by telling something else to this patient. Okay, something that might have misled. No, you're absolutely fine, don't worry. We are taking proper measures. We are going to bring this particular doctor from that particular bigger hospital or higher center, and we are going to do more tests on you. Okay, so, and that is not going to help. Okay, so it's kind of misleading a person. So it is actually really not right to deliberately mislead a person, or withhold information that the patient is asking for at the insistence of the patient's relatives. Next slide. So this is another example, and this is a 50-year-old lady with a carcinoma of the stomach, and she has come to the hospital in a terminal state. And this particular terminal state is because of the cancer and due to some kind of internal bleeding. Her systolic BP is 50 millimeter of mercury, and she is extremely restless. So the question here is, will you give her parenteral midazolam, which might hasten her death? So any comments from your side? Okay. So Dr. Tinu says yes. Dr. Purva says no. Okay, midazolam can see. Okay, no. Midazolam can help with anxiety. No. Why is she like that? Okay. No, but try to calm her anxiety, which midazolam can help with. Okay. She needs to be made comfortable according to patient's relatives. Okay. I'm so sorry. Sorry about that. Okay. All right. So, yes. So now the information that this particular case has is that this lady is a cancer stomach patient. Okay. She is in a terminal state. All right. Let us take the information from what we have in the case. Cancer stomach in a terminal state. Terminality is because of some internal bleeding, and internal bleeding, when it happens, definitely there has to be some kind of a bleeder inside the stomach, which has not been taken care by treatments that might have been given previously. So that is why she is perhaps in a end of life. Okay. Now, because of the internal bleeding, the systolic BP has fallen down to 50. She is restless. The question is, will you give parenteral midazolam? Let me just tell you, you'll be learning this in your end of life class also. Midazolam is the gold standard for terminal restlessness. Okay. We have to give midazolam to calm this patient, because restlessness is the one which she is suffering from as of now. Okay. This is where we need to put her into, calm her down, as many of you have said. Okay. Midazolam is going to take care of that. This is the gold standard. Now, the question is, how are you going to justify this to your colleagues who are going to ask you a question? Why have you given midazolam to a patient who has a BP of 50? Okay, the patient is anyway going to die with midazolam. Why have you done this? Now, next slide, please. The dilemma is, will it be right to give some medication to a terminally ill person, which may inadvertently hasten the person's death? Okay. The point is, when we know that the standard goal treatment is of terminal restlessness is midazolam, we will have to give the patient that relief, because that relief is the patient's right. We cannot just leave the patient to suffer in terminal restlessness. Okay. She is suffering because of the restlessness and not because of the cancer, not because of the falling blood pressure. She is suffering because of the restlessness that is happening inside her. Okay. So we will give midazolam here. Now, how are you going to explain that to your colleagues? The point is, next slide, please. We need to understand the principle of double effect here in this particular case. And there'll be many other cases where, you'll need to justify the principle of double effect. So what it means, it is a single act of having two possible foreseen effects, one good and one harmful, which is not always morally prohibited if the harmful effect is not intended. Okay. So it's as simple as that. You are using midazolam for a terminal restlessness. You know that by using midazolam, your patient is going to calm down. Your patient is going to get relief. You are 100% sure of it. But at the same time, there is a harmful effect that is tagged with midazolam. And that harmful effect is, perhaps it is going to hasten death. Perhaps midazolam might induce death. The patient might die during the midazolam infusion. Okay. Now, your intention is not to, make the patient die. Your intention is to provide relief to this patient. And henceforth, your justification is that my patient needs to be calmed down during the last phase of our life. And hence, this is the reason why I'm using midazolam. I also know and I'm aware that it might happen that the patient dies during this infusion, but she will not die in a restless position. She will not be suffering anymore. And that is why I'm using midazolam. So there are numerous other examples. For example, we use oral morphine for pain relief, right? And morphine has side effects. What are those side effects? Constipation. What else can you think of? What else can you think of? Nausea, vomiting, drowsiness. Yes. So, so these side effects, are we intending to induce these side effects to our patient? No. What is our intention? Our intention is to manage pain. Yes, delirium myoclonus, absolutely. So our intention is to manage the pain. And we know that by using morphine, 100% pain relief will be there for our patient. Okay. So are we thinking that, oh my God, my patient is going to suffer from drowsiness. My patient is going to suffer from delirium. I am not going to use morphine. Let the patient suffer in pain. Will we be doing that? We'll not do that. We will definitely put the patient on morphine, relieve the patient of the difficult pain that he or she is undergoing. And at the same time, we are also wary of the fact that these side effects might occur. So we'll take precautions so that these side effects can be curbed. Okay, so this is double effect. Let me give you another non-palliative example. So, there are many people in and around you, in your family also, who might be taking hypertensive drugs or, anti-diabetics. So they also have, anti-diabetics have a tendency to, cause a fall in sugar. Are you not going to give this person anti-diabetics just because that he might have a low sugar at one point of time? Okay, no. So it is the same thing. So every agent that we use, whether it is for pain relief, whether it is for restlessness, whether it is for, any kind of procedure also, any kind of procedure that like amputating a limb, okay, amputating a limb when the patient has suffered a crush injury where you need to, cut off the patient's limb. What is the side effect? What is the harmful effect there? The patient is going to suffer psychologically. The patient might have something called the phantom limb pain. Okay. So are we not going to put the patient through that treatment only because we will think about the harmful effect? It is not like that. So what we are going to do, we are actually going to justify to us first and to our colleagues and then to our patients that this is going to give you this relief, and at the same time there might be an harmful effect tagged with the solution. Okay, next slide please. So another ethical dilemma situation here. So this is a 74-year-old gentleman with advanced carcinoma of the lung. He had completed a course of radiotherapy and 2 courses of chemotherapy. He is brought to the casualty in a drowsy state, very feeble pulse. The systolic BP is 60. Breathing pattern is altered. Okay. The family wanted everything possible done for him, right? So what do we do in such a situation? Already 74 years old, advanced cancer of the lung, already treated with chemotherapy, radiotherapy. Okay, now he's slowly perhaps going away from us. Okay, all his parameters, his drowsiness, feeble pulse, low systolic BP, altered breathing pattern, everything is actually, pointing towards a end of life. Okay, so you will definitely be knowing more about end of life in your next classes. So what do we do in such a situation? Do we resuscitate and shift him to the ICU? Can I have an answer to this question? Do we resuscitate and shift him to the ICU? Yes or no? Okay, I get something from no, no, no. Okay, there are a lot of no's here. All right. Okay, then, okay, there's one yes from Dr. Kamla, I think, yeah. All right. And okay, coming to the next question, do we investigate further? Do we investigate further? No. Okay, fine. What about the hemodynamic and ventilatory support? Do we do that? Do we put the patient on ventilation? Okay, there are no's here. No ventilation. There's one person who says yes. Okay. Why yes? Why do you say it's important for ventilation? Maybe to look for treatable causes like sepsis. Okay. Okay, the family wants to, okay, all right, all right, all right, all right. Hydration and nutrition, wish of the family. All right, okay. So, all right, so this is a tricky situation, the family has resources. The family can actually get this person to the ventilator. Okay, they can put him through that. But do you think, what is the goal of care in this particular situation? What do you think the patient is going to have after we put him, after we resuscitate him, to shift him to the ICU, put him through a lot of investigations, do everything possible for a hemodynamic and ventilatory support, all things done for maintaining hydration and nutrition. So yes, Dr. Tinu says it's only pain after surviving. Absolutely. So can we go to the next slide, please? So this actually brings us to the question of what an appropriate treatment is. Next, please. So we need to understand as physicians that the treatment that does not provide net benefit to the patient may ethically and legally be withdrawn, and the goal of medicine should shift to the palliation of symptoms. Okay, so this particular statement is as crystal clear as you can read it, because it justifies our decision of not giving any kind of treatment that will not give any kind of benefit to our patient. Is ventilating this 74-year-old person with metastatic lung carcinoma, who's gone through a lot of treatment, lot of radiotherapy, lot of chemotherapy, without any benefit till now, and now going to die because of this disease? Do you think shifting him to the ICU, putting him on a ventilator is going to give him any benefit? He's going to suffer more. We have to understand that. Okay, I know there'll be questions, and we are actually going slowly to discuss those. I know what are the questions in your mind. I can see some of them. Okay. Dr. Puneet says those life prolongation events only will be giving painful death. Absolutely. Explain the family for his peaceful death. Yes. So yeah, so there will be it should help a family in bereavement process. Yes, we will come to yes. Okay, so they have done the best. Absolutely. I agree with this, Dr. Christine, that it will help the family in bereavement process, and they have done the best. Now we will need to guide the family whether by putting the patient into the ventilator, have they really done the best? Okay, because they have not seen hello. Yeah, so they have not actually seen the scenario inside the ventilator. What happens? They have not. They will always be looking it from the side that they have put their patient into the ventilator. They want to save him at any cost, and that cost might also be jeopardizing the relief of the patient. Okay, so we will need to understand those dynamics also. I completely agree with you, Dr. Christine. But having said this, we will also need to show the family members the other side of what might happen if we put a dying patient in a ventilator. What are those problems? What are those those difficult times that a patient faces alone in a ventilator? Okay, so those things, that picture, we need to actually explain it to the family members. Yeah, next slide. So the appropriate, when we speak about appropriate treatment, the key points that we need to understand are the patient's biological prospects. Okay, what are the test reports going to reveal if we keep on investigating him? Okay. Secondly, the therapeutic aim and benefits of each treatment that we devise. If we decide on giving the patient into the ventilator, what is the therapeutic aim? Are we going to, are we going to get the patient out of the ventilator after a certain period of time because the patient is going to recover for putting him into the ventilator? At the same time, the adverse effects of each treatment. What are the adverse effects of putting this patient into a ventilatory support, into the, maintaining hydration, maintaining nutrition, giving the patient, all sort of IV drips that we know of, okay? The need of not prescribing a lingering death, because we are actually holding the patient back from proceeding to a process of death. And that process of death is actually, going to be more painful if we start aim of putting the patient into the ventilator and giving him all sort of medications that might not lead us to a beneficial effect. Okay, so please remember these appropriate treatment key points. You need to devise your own treatment key points here. Okay, next slide, please. So this brings us to the act of justice, what we want to do. Okay, why we need to have the principle of justice acting here. And justice is actually balancing the needs of the individual with that of the society. Next slide. So I'll take one example to explain about the principle of justice. This is an 86-year-old journalist, and he's a 1971 war correspondent. He's a thinker, he's a writer. He has been suffering from lung cancer, which has spread to the spines, the ribs, and the sacrum. He has a son who's basically a psychiatric patient. He has 6 grandchildren, and our goals of care are actually revolving in and around the pain that he is undergoing because of all the bony metastasis that he has, the finances of the family, going towards towards taking care of both this person and his son, who's also a psychiatric patient, and at the same time, the grandchildren also. The patient as such, wants to see his 3 grandsons going through a Janevu Sanskar. Janevu Sanskar is a kind of a ritual that, takes place in Brahmin families, where they put a sacred thread for these children, for these sons. So the goals of care are actually revolving in and around these things. Okay. And at the same time, the patient is actually dying. And that is evident with the increasing breathlessness that this patient has. Next slide, please. So do we actually consider ICU admission for this? The question of admitting 86-year-old patient with a terminal disease, where the cash flow is actually limited to many other resources, his grandson, his family, the psychiatric disorder of his son, etc., etc. And the goals of care that we have devised for this particular patient. Do you really think that ICU admission is needed for this patient? No. So yes, I get a lot of no from here. So why do we say no for this patient? So next slide, please. So, next. Yeah. So is this a fair utilization? If we do that, if we go even, we know that perhaps, taking this patient, the family might also want him to put him in the, but then is this a fair utilization of the family's resources, where much of the cash flow is into the, taking care of the family? At the same time, do you think the hospital resources would be fairly allocated? Okay, you have 6 ICU beds, out of which, this patient is going to take 1. All right. At the same time, the patient may not be able to come out of the ICU at all. All right. You have a young person who's just had a head injury and come to your hospital, and you really don't have a bed for that patient, whereas that patient could be saved by admitting into the ICU. All right, where you have actually allocated this ICU bed to a dying patient. All right, so we need to think about fair utilization of our resources that is available to us. And India is a resource poor country. I've already told about this in the beginning, and we need to justify why we are, giving one person some amount of more resources than the other. We have to justify a fair allocation, fair utilization of all kinds of resources that we have. Okay, next slide, please. So this brings to, the concept of euthanasia. So you all know about that patient who was in Mumbai hospital, the nurse who was, in the ventilator support for around 30, 40 years. And, she was in that ICU bed for a long time on artificial hydration, artificial breathing, everything artificial. And, the whole case story was regarding what to do next, because it went on and on and on. And that was a time where the Mumbai High Court had, given up on this particular patient and had asked the ventilatory support to be removed. Now, do you think this is euthanasia? What do you actually understand about this particular thing? Yeah, any comment from your side? Any comment? So this, euthanasia is a very sensitive topic. It is a very difficult topic to understand. There is a slippery slope where you tend to fall down. Okay, so it is always an act or procedure in which someone takes active means, such as a lethal injection, to bring about someone's death. All right, so you have taken, an ample amount of a lethal mixture of morphine, midazolam, haloperidol, and so many other things. You have mixed it in a cocktail, and the patient and the patient's family, they want you to give that injection to bring about somebody's death. Okay, so this is definitely euthanasia. Okay, but allowing natural deaths to happen, all right, by withholding or withdrawing a futile treatment is not euthanasia. Let us understand this particular thing. Okay, It is legal in Netherlands, Belgium, Luxembourg, and few more other countries which I have not mentioned here. But we need to understand the difference between taking somebody's life, okay, and allowing natural death to happen. Let me give you an example. So a cancer patient with metastasis to the lungs and bones and so many other organs, presently with a restless situation, is now going to going towards the end of his or her life. All right. And the patient is now being brought by the relatives to your hospital. Okay. The patient's family is actually, one of these guys in the family takes you to a corner and says, "Doctor, my father is suffering since a long time, and I really don't want to see this happen, but please do something. Please give him the final injection so that he goes off." Okay. So, many things like this have happened actually, true to my knowledge, and with, many times with me also, because people ask me, "Doctor, when are you going to give him the final injection?" Okay. So this particular term of final injection, they mean that they want their patient to die. So are you morally obligated to do that? We are doctors and we are meant to save lives, and we are not going to bring about somebody's death. All right. But having said this, if I say that I will not admit your patient inside the ICU, nor will I ventilate your patient, is not euthanasia. I am not committing a crime, or I am not committing murder by allowing natural deaths to occur for such a patient. Okay. So understand the difference between allowing natural deaths and doing the procedure, or giving an active lethal injection, which amounts to euthanasia. Next slide, please. So in the IPC section 88, there is a legal provision for allowing natural deaths to occur. But unfortunately, because of many legalities, many issues, this particular section has not actually come into a proper practical application. Okay. But earlier this year, 2023, in January, the whole system of withdrawing and withholding such processes have been simplified by the Supreme Court of India. Okay, I will not go into details, because I think in end of life care, the faculty will definitely be mentioning this particular process to you, where withholding and withdrawing treatment does not amounting to euthanasia will be explained to you. Okay. And as doctors, we will have to protect ourselves with the laws that govern our practice, and henceforth you will also need to know this particular section. Okay. All right, next slide. So the term futile care, when you talk about futile care, it means that you are actually going on and on and on, giving some kind of treatment to a patient, okay, just because you think that you are morally obliged to deliver that care. But then, having said this, the AMA Code of Medical Ethics of 2009, very clearly states that physicians are not ethically obligated to deliver care that in their best professional judgment will not have a responsible chance of benefiting their patients. So as physicians, we are not ethically obligated to deliver any kind of care or any kind of treatment that might not give a reasonable chance to our patients for a proper benefit of their life. We are absolutely, so try to find out your environment where you feel that whatever I am doing today for my patient is going to be futile. You have to define that futile care for your patients all by yourself. And of course, there are a lot of other discussions that go on when you talk about futile care. Next slide, please. So bringing us to the question of why doctors go for futile treatment at all. What is the problem? What are those situations where we feel really very difficult and insecure that we keep on treating our patients? Next slide. So we as doctors, we are oriented to curative treatment. We have, when we first entered our MBBS courses, all we knew about being a doctor is that we have to save lives, right? So we are already oriented to cure our patients. We need to cure. If we cannot cure, that means, we are a failure. Okay. But we need to understand that even if we do not cure and give only relief to our patients, that actually amounts to a lot of good benefit to our patients. Okay. And unfortunately, palliative care has been there, but not, very professionally aligned to our courses. We do not really have any kind of palliative care training. I'm talking about my days way back in the 90s, where there was no concept of palliative care at all. Okay. Palliative care generally makes you accept failures in your professional lives also. Basically, when you are dealing with end of life, basically when you're dealing with diseases like HIV, cancer, Alzheimer's, dementia, certain neurological disorders where your patient is bound to die or, bound not to get better over time. All right. So it actually prepares us as, to take on death as a normal phenomena of life. And then, of course, there is always a fear of being blamed for suboptimal treatment in, that this doctor has actually not given any injection to my patient when the patient was lying, there in the ICU bed, or, the doctor has refused to give him into ventilation. There was no oxygen. All these things of being blamed for suboptimal treatment, where we know that this particular treatment might not help the patient anymore. Okay. And then there is a lot of ignorance about the guidelines for end of life. Okay. When you do your classes on end of life care, you'll definitely come to know about the proper guidelines that have been set by proper associations. All right. And then the question of euthanasia always lingers. It's like a sword that is always hung over your head. Next. So this is the guideline that I'm talking about. I would insist all of you to please, go through this end of life care policy. And this is a joint position statement of the Indian Society of Critical Care Medicine, and the Indian Association of Palliative Care, you get a proper 12-step, guideline for how to approach a patient at the end of life care. And at the same time, what are the things to do and what we should not be doing, So this generally is a kind of a principle that has been devised to protect ourselves from treating endlessly, treating our patients endlessly, and at the same time saving us from the extra burden of feeling that we are we could not save our patients. So an end of life care policy guideline is a must in every palliative care physician's kitty. Next slide, please. So just to think about something, two important phrases or two important concepts of what is killing and what is letting one person die. So there is a moral distinction between both these two concepts. Are we killing somebody or are we letting that person die? And in what circumstance is it morally justifiable for not to offer life prolonging and life sustaining treatment? Okay. You see, some people, even us at one point of time, but we are going to die. That is a truth in life. That is the only truth in life. Okay. Dying is only truth in life. But when we do something to kill somebody that amounts to murder, it is not letting die. There is a huge difference between both these two concepts, and we have to understand that when we are letting somebody die a natural death by not offering any kind of life prolonging and life sustaining treatment, we are actually not killing anybody. Okay. So this concept, if you are clear at this particular concept, you'll be able to justify why you have not offered ICU or ventilation to a dying patient. Next slide, please. So that brings us to again to this particular concept of euthanasia. So it has to be a deliberate intervention, and it cannot be equated with a concept of withdrawing or withholding treatment for our patients. And there is no concept of passive or active euthanasia, because euthanasia itself is a deliberate intervention. So there is no passive euthanasia at all. There is just one single concept, which is only euthanasia, and it is a deliberate intervention. Next slide. So, when we talk about do not resuscitate or the DNR concepts, which is now very much applicable, in India also. All right. So we need to understand whether, not resuscitating a patient according to his or her wishes, is that amounting to any kind of crime? It is not. That is the reason why people working in ICU setups or even end of life care setups will need to put forward the DNR concept to their patients and the patients' families. Next slide. So we actually, yes, can we move to the other side? Next slide. Okay. All right. So can you just take the other slide, the previous one? Yeah. So I No, the other one. Yes. So I wanted you to show this particular book. If you want to read about, the concept of our medical system, many other concept that has been, put forward by people like Atul Gawande. Atul Gawande is a neurosurgeon in the US, and he has written a big book called Being Mortal. I'm sure many of you might have gone through this book, might have read this book already. And he very rightly chooses to criticize our medical system, or, in um, uh, where, we keep on treating our patients to the end point. Okay, but unfortunately we generally do not realize what the patient goes through. So please go through this book called Being Mortal, and it will actually clear out many of your doubts, because there are case studies in this particular book which will actually give you an insight to how palliative care might help our patients to get the best treatment, at the same time save him or her of the endless suffering that patient might go through in a ICU. So next slide would be the last slide. I just wanted to show you why we do not want to die in the ICU. There'll be many other slides, but I think, Sri Priya, are we running out of time?
We have precisely 9 to 10 minutes more.
Okay. So are there any more slides in this PPT? I think. Next. Yeah, so these are certain statistics that you can see. We do not want to die in the ICU because much of our healthcare spending in India is out of pocket. 39 million Indians are becoming poorer per year due to the rising healthcare costs, and this is according to the Lancet. Most are related to aggressive medical interventions at the end of life. So you understand why we do not want to put our patients into the ICU, especially those patients who are in the end of life. Okay, we will actually need to pinpoint those patients who are at the end of life. Okay, and that is left to the palliative care physicians only. And then, of course, there's a 300% increase in inpatient expenditure in the last 10 years, which is actually projected to increase by another 100% in the next 20 years. Okay, next slide. So at this particular background of ethical principles, we need to have a proper respect for life and the acceptance of the ultimate inevitability of death. So this is the take-home message for you today. Having said this, the dilemmas that we will face while justifying our actions will always be, backed up or, covered up by good communication skills. And once you know what to communicate and what not to communicate, the balance becomes very easy. And at the same time, you have the patient and the patient's relatives by your side, so that you have a complete team who is actually, uh, stamping on the decision that you have taken for this particular patient. So I end my presentation here today. Thank you so much. As you can see on the right hand side, this patient is also at the end of life, and she is being supported and taken care of by her relatives, her daughters perhaps, all surrounded. And on the other hand, this cartoon character, we do not want to jeopardize the dignity of our patients. That's why I've used a cartoon character here, is actually surrounded by machines. All right. So maybe, putting in a little bit of our emotions and trying to balance out how we treat our patients during the last days of their lives is also very important in our lives. So thank you very much for this patient hearing. And I'm really sorry for all the trouble that might have happened in the middle. So any questions that you may have, I'm ready to.
Dr. Veena has raised her hand. Dr. Veena?
Yeah. Yeah. Ma'am, end of life, when patient is an end of life situation and they're already on the ventilator, can we disconnect the patient from the ventilator?
That is a ethical question, actually. That is a ethical, but then I really don't think that we will be able to disconnect the patient from the ventilator, because the patient is already in the ventilator. All right. It will be very unethical to withdraw that. But having said this, there are provisions now, which I actually told you, in the beginning of this year, withholding and withdrawing treatment. This particular thing has been very properly laid down by the Supreme Court of India. They have actually legalized and actually made these things very simple. Okay, if you have to do this, there is a certain procedure of presence of a CMO, presence of a judicial person and many other people. And there is a step-by-step process for that. Okay, so, and that also needs to be understood by the patient who might have been in a better position before going into the ventilator. All right. So, and that is definitely, a process of DNR. So you will have to document everything before the patient goes into the ventilator, and at a point where the ventilator might not be justified for the patient, and you want to withdraw that patient from the ventilator. So does that answer your question?
Yes, ma'am. Thank you, ma'am.
Ma'am, we have one more question. If we give midazolam to that patient who is restless, will their family members not blame us?
Exactly. So that's what we said. So whatever decision you take, you will have to explain it to the family members. So I think in every slide, I have told you that you have to take the family members by your side. And for that reason, if you need to, keep on interacting with the family members and the patient or anybody else who is a close friend of the family, you will have to do that parallelly, and I know it is a difficult decision at that particular point of time, but you will always find it easy when you do that parallelly. There are situations we face where there's a triage and the patient is actually sinking. There would be around 10 people from that particular family who's actually crowding you on your shoulders and asking this and that. So you will need to manage that situation. Keep your cool all the time. This is something, sometimes we lose our cool. Sometimes we the nervousness actually comes upon on our faces. I think that is where your communication skills will help you. Take it from me, because I have faced this every now and then, specifically with the end of life of cancer related patients, because people do not accept that a lot, for a long-standing disease like Alzheimer's or HIV/AIDS or something like that. The acceptance would be there because they'll be chronically living for a long period of time. But for those patients who have just been diagnosed with a metastatic cancer, and it's not even 3 or 4 months that they are actually going down the hill. And that's where the acceptance of family members as well as the patient is zero. And where you need to, use palliative sedation or midazolam for restlessness, I think your communication to the people, to the parents or to the relatives will start from day one that you have seen the patients. You will not see the patient, from just at the point where you need to give midazolam. The patients would be actually visiting you from maybe 2 or 3 episodes. And from day one, your prognostication, your prognosis, your communication with the onco department or the primary department who's taking care of this patient will start. And please do not jeopardize that. Please do not undermine the effect or the importance of communication here. Because if you communicate, if you tell everything to your team, to your other people in the management, and also the family members, it's always going to work. There's no chance that they're not going to accept it. Am I sounding very filmy or something? No.
No, ma'am.
You have to talk. You have to talk. It's very important that you talk. If you do not, it will never work.
Dr. Apurva want to ask something. Dr. Apurva?
Ma'am, thank you so much for such great information. A lot of doubts have been cleared, but I just wanted to know in 2 scenarios, what if your scenarios which you had mentioned that cleared a lot of things, but still I am in a little more doubt. If it's a very terminal illness, the family wants the patient to survive, but the patient is at the verge of too much of serious discomfort. The patient wants the end of life, but the family is really forcing into, we'll invest a lot of money, we'll do the best we can to extend that life. That we discussed. But what if the situation is reversed? When the family is a little short on funds, we can say, but the patient is really keen on surviving and making sure that I will keep a positive mindset, I will try to do something which will actually increase my lifespan. So in that situation, when we are left in a fix between the patient and the family, whom should we actually focus on understanding and like giving the care to the patient and the family?
So, this is not a very uncommon situation. It happens usually when the patient is young. Okay. And the patient has somebody in the family who is dependent on him. For example, a young wife, a small child, he's a father and the child is just 4 or 5 years old. And he knows that he is actually going down the hill, Let me tell you from my experience that such patients actually know that they are not going to survive. Okay. But still they want to do everything because that is a kind of a coping mechanism that they are taking on to accept the fact. They the wife actually perhaps knows, and the parents of this particular patient might also know that he's not going to make it. And at the same time, whatever we could have done in our limited funds, we have done it. Okay. But the patient is actually trying to cope up with that particular situation, that no, there is something that might make me survive, and I can actually come out of this situation and take on the family responsibilities that I used to have. Okay. At this point of time, my sincere advice would be not to give that patient any more advices that you want to. There should not be any kind of it's like, all right, fine, I understand that you want to come out of this situation, and you have to believe me that we are trying our best. Okay. So this particular reassurance from your side that we are trying our best for your thing to be made up gives him the assurance that whatever happens, they're also trying. My family has also tried. I am also trying, but still we are not going to that goal. This is going to take some more time for the patient to actually tell you that, doctor, I think you have done your best. I'm really thankful to you. And I know that I will not be surviving anymore. So, this might, be a little dramatic, but it actually happens like this. Give that particular patient some more time. It is not going to end in one day. It will, be up 3, 4, 5 weeks also. And there are patients who will drag you to the last day of their life also. There would be a lot of dissatisfaction in you also. Please take this for, this is something that, yes, we need to perhaps condition ourselves on that, because that is our acceptance. Because if we do not do that, then we will be on the other side of the professionals who tell us, oh, palliative care is so depressing. So I have a lot of friends who actually know, you are in palliative care. Shit, it is such depressing, because, they cannot take that for acceptance. And these situations which you talked about is actually, it happens a lot of time. Okay. We cannot make our patients or the families happy at any point of time. But then, yes, at one point of time, there will be a closure to everything. I don't know whether I'm able to answer your question or not.
Ma'am, a little extension to the same question which I'm asking. In these terms, how much information should we be providing the family, the patient, or should we keep something under the wraps to make them not too much into that depressive state that now this is like the end of life? So should we keep something under wraps, or should we be very, very transparent in sharing the information?
Absolutely transparent in sharing, but you have to find out how much they want to know. Okay. How much they already know. And these are the basics of communication. These are the basics of communication. So you find out how much they already know and how much they want to know. Sometimes, there will be patients who say, I really don't want to know anything about my cancer. I just don't want to know. And you feel that, oh, in communication skills, we have been told that we have to give all the truths to the patient. It's not like that. It is like, you act according to your conscience, your intelligence, and you find out where the patient is. You find out how much the patient has already known about the disease. You find the misconception, you explore reasons, and then you decide how much you have to give. Okay. And intentionally, if the patient wants to know everything, it's a great opportunity for us to tell him what he is, where he is, and where he is heading. And there would be definitely, there is a process to let the patient know, step by step, sometimes a little, sometimes a more, not like a bomb exploding at the same time.
Thank you, ma'am.
Thank you, ma'am. I believe we can wind up for the day. Thank you. Thank you, ma'am, for the wonderful presentation. And we had very good input from the team members. Thank you all. Thank you, ma'am. Over to you, Sri Priya.
Thank you, Dr. Sanghamitra. As always, an inspiring and interactive session as expected from you. Thank you so much. Thank you, participants, for making the session interactive. And we do request everyone to be this much interactive in the coming sessions as well, because we are bringing in faculties from different parts of India to enlighten us on the topics which are very less discussed in other forums. So we would request everyone to make maximum use of this opportunity, with a promise that we'll be again meeting on the next session with an introduction to communication with an eminent faculty. This is Sri Priya, along with Dr. Sanghamitra Bora, Dr. Arjun, and Mr. Anup signing off from the Deep Psycho Hub. See you in the next session. Till then, everyone, take care. Keep spreading happiness. Bye-bye.